Thanks for the opportunity to conduct this session. I think lung cancer treatment is seeing a very, very exciting change in the last 3 to 4 years. A lot of activities going on, especially in this group of patients, stage 3 and locally advanced lung cancers, NSCLC. I'd like to invite Dr. Ghanashyam Biswas, Consultant Medical Oncologist at Sparsh Hospital, Bhubaneswar, to start off with the proceedings and so that we can go on.
Good morning, and so I'll try to finish in time because I have to catch my flight. So thanks Dr. Sarvana, respected JP sir, our teacher. And so we are talking about, so we are moving gears from a metastatic disease to a locally advanced. So today's hero seems to be a stage 3 lung cancer. So we know that probably we don't know much now because as the story unfolds, so it looks like a Pandora's box. So where you can put surgery, chemotherapy, radiotherapy, immunotherapy, and now even targeted therapies. So we have medical oncologist and we have a radiation oncologist and a surgeon. So I thought let us choose your options wisely because so we have been a part of the Kindle study. It was initiated by Astra pre-COVID. So where we went through the retrospective files to look at so how stage 3 behaved. So this was an initiative because Durva was coming into picture, and we find that so if you really stage them well, so there are many patients who actually belongs to a stage 3. So these are the panelists and the chairperson who are gracing this panel discussion today. So we will be focusing on stage 3 lung cancer, so N2 disease and N3 disease. And N1 we know that ipsilateral mediastinal nodes, N2 is a contralateral, and N3 is beyond that. So what constitutes a stage 3 non-small cell lung cancer? So Dr. Vivek.
Slides are there. Yeah. So stage 3, no N2 and more than 3 lesion T3. Usually we don't get so much patients. Like our data is less than 10%. So usually it is done by surgeons or by radiation. So it's okay.
Yeah, Dr. Arif.
Stage 3A, it's like more than 5 centimeters N2, and it is a heterogeneous group, 3A, 3B, 3C. 3B comes the N3 nodes and anything and 3C is almost the locally advanced stage. So we have got heterogeneous group which to be resected, which not to be resected. Surgeons decided usually it's single station or discrete nodes. Which get resected, and so it's a lot of controversy how to treat these patients. Depends more on how the surgeon assesses and.
So Sarvana, so since being a surgeon and thoracic, so how commonly as a surgeon, so you come across or encounter stage 3?
Actually, in our hospital, all patients who are metastatic, they don't even come and see me. They just directly go to the medical oncologist. But we are seeing increasing number of patients, especially after the COVID pandemic. Now, anybody who is coughing is getting a CT scan, which was earlier X-ray chest before. So, and more patients are coming to us in locally advanced as well as early cancer. In fact, during the pandemic, we got a lot of stage 1 cancers, and immediately after the pandemic, we are seeing a rise in the number of stage 2 and stage 3
lung
cancers.
cancer and Hodgkin's disease.
Yeah. So because the CT scans actually have become cheaper, and more physicians are now referring for a CT scan outside, and we are getting more of this group of patients. And like he mentioned, stage 3, anybody with lymph node positivity in the ipsilateral mediastinum or contralateral mediastinum, this is an important defining factor, or a large lesion in the primary, which precludes or which will make primary surgery a little difficult or tedious. I think this in general terms will define what a stage 3 would be. And
JP sir?
It's classically a very heterogeneous. Means those who are not in stage 1, 2, or they are all metastatic, then whatever is left behind is kept in this. Classically, a contralateral supraclav is really a part of stage 3B, right? Ipsilateral with a large tumor, again it will come to. So it's a really mixed bag, and we need to be very carefully dissect out what is this stage 3 and then decide the treatment.
So absolutely. So most of these patients will have an unresectable tumors, and you can see the survival. So according to the AGCC 8th edition, so you look at so the clinical and the pathological. So stage 3A, B, C. So in a stage 3A, something 5 years survival is something around 30 to 40%. Coming to stage 3B is something around 25%. Stage 3C is around 10%. So if you compare it to stage 4, so that's absolutely a need to understand or segregate this disease, because you have an improved survival and you have few patients who can be a long-term survivor. So that's the importance of picking up stage 3A, B, C, and especially a stage 3A and B. So coming to staging of lung cancer, so I'll move to Dr. Anil, so radiation oncologist. So how do you stage this? So we are talking about non-metastatic disease.
First of all, we have to do a PET-CT scan is just to confirm it's a non-metastatic disease. And as far as the mediastinal staging is concerned, there are two types, that the radiological staging as well as the invasive staging. So invasive staging, as per the availability of the E-bus, either you can do the E-bus and followed by mediastinoscopy. If the E-bus is still positive, then you confirm with the mediastinoscopy. And obviously the MRI brain is to rule out the brain metastasis. So that will complete overall staging purpose of stage 3.
So coming back to Sarvana again, so how accuracy is your non-invasive staging and how accuracy is invasive staging?
See, in our country, we did a small analysis in our group of patients. We found that around 40% of PET positive patients, after when you do an invasive staging, they all tended to be false positive. So the literature says that 20% in Europe and US, 20% false positive with a PET positive lymph node and 20%.
Maybe because of tuberculosis or something?
Yeah, tuberculosis, granulomatous inflammation, sometimes silicosis. We've got.
And now COVID.
Yeah, COVID. We have sarcoidosis. Lot of factors which increase the avidity in the PET image, and so it makes all the more important for us to, if accurate staging is part of your philosophy to guide management, I think in our country invasive staging plays a very, very important role.
Yeah, so coming to a non-invasive CT versus PET-CT, so around 43 and 45 clinical trials, you look at the sensitivity in CT 55 versus specificity 81, PET 80 versus 88. So definitely PET-CT supersedes CT scan. And now coming to invasive staging, so be it a mediastinoscopy, then comes to endoscopic ultrasound, then EBUS, so definitely the sensitivity improves. So how commonly you encounter or patients, you get patients for a mediastinoscopy?
How commonly we do mediastinoscopy? So in we have EBUS in our hospital. So we start off with EBUS always, and only when the decision is going to change the management of the patient. I'll give you a scenario. If the patient has a contralateral N3 station lymph node on PET-CT scan, and you did an EBUS and it came negative, I will definitely go in and confirm by doing a mediastinoscopy whether it's positive or negative, because it is going to change the entire mode of treatment. However, if there is a single station node on the ipsilateral side and EBUS came negative and it is a resectable, that is small, 2 centimeter size, easily in the resection zone, I will not push for a mediastinoscopy. So if the decision is going to change the entire scope of management, I believe that mediastinoscopy should be added to a negative EBUS also. However, in most situations we usually are easily able to, so in our country people will come with large N3, you do EBUS, now the EBUS needles are so big, you can do molecular testing from the samples. So I think accurate staging, EBUS is very good if you're in trained hands. If not, do a mediastinoscopy if it's going to change your management.
So if you think that your patient is deemed for a surgery, now how do you work up?
So any patient in lung cancer especially, it's very important compared to all other cancers that physical fitness forms an important part of initial assessment. So in addition to staging, and then you found out that the patient is operable or resectable, then we usually do a physical testing in the form of a cardiac testing, 2D echo, and a pulmonary function testing, which includes a PFT and a DLCO. So these three are important for assessing whether your patients are fit enough to undergo surgery, because surgery is morbid.
So Dr. Manish, so how important is role of MDT? Is important for all cancers, all stages. So how important, and who are those stakeholders in a locally advanced NSCLC?
Actually, you have mentioned everything in great detail. So, in all MDT, mainly the three components, like when we are except early stage lung cancer or stage 3, we do involve surgeon as well as radiation oncologist, and nuclear medicine specialist also important for a PET scan, and then for pathologists because of the molecular testing that we get to do. So basically, everybody is involved. There's no treatment in isolation nowadays, so we have to involve everyone.
So Sachin, so any role of biomarkers? So we are talking about so much in advanced lung cancer. So now, what is the place for a biomarkers in?
So in sir, in the early stage, EGFR is important. We have got ADURA and also PDL1 may be important in the coming days because we have adjuvant immunotherapy options also now. ALK as such, not at present, maybe as a prognostic marker that ALK, the immunotherapy doesn't work in ALK positive cases in the metastatic setting and also in the adjuvant setting. So as a prognostic marker, but therapeutic marker would be EGFR and PDL1.
So Vinayak, so do you think that we go all the way to NGS because all road leads to NGS today? It's almost an holy grail in all cancers.
I'm doing NGS for all cancer across. I think last session also I told. Maybe the option which given by Dr. Ullas sir is not available for me. I cannot get report within 2 hours, within 1 day or 2 days. I go for a 12 gene panel for everything, for all lung cancer. Because
since we are talking about locally advanced.
Still do it. I'll still do it.
So anybody else? Sachin, Arif? So yeah, Abhishek.
So the just multi-gene panels are not NGS in everyone because we don't know how to act on it, act on that report, whether it will change the adjuvant treatment or not. So I will test for EGFR and PDL1 at this time. Maybe in the future, if you have got many therapeutic options, and you should not confuse us. The report should not confuse us what to give, what not to give, because the trials show benefit in some patients, subgroups, some not in other subgroups. So I would do EGFR and PDL1 for which we have got some therapeutic options.
Most of these patients are going to fail sooner or later, no?
Yes.
So does it make sense to have an NGS, though we don't have a data at this moment?
So as we know that most of the biomarker-driven lung cancer do not respond to immunotherapy. So in those cases, I think in locally advanced cases also we need to go ahead for NGS. But presently, whatever data we have is for EGFR, ALK and PDL1, based on which we can prognosticate the patient and discuss with the patient regarding the pros and cons of all these positivity and the role of immunotherapy as well.
Yeah, now the whole world has arisen and asking for mutations even in the early lung cancers because after the significant role of ADURA. Yes, please.
I just wanted to know, as sir said, that most of the patient, almost 70% of the locally advanced disease are going to come back with metastasis. And if you do an NGS at previous, like when the patient is stage 3, do you honor the same report when the patient comes with metastasis, or you want to change?
Today we know this is a dynamic. So as far as possible, as many times possible, you need to do a repeat. So it should be at least 9 months or a year old. So then probably otherwise you need to do because it is so dynamic. No? So you'll pick up new mutations, then the old mutations are gone.
So he is asking, is it relevant to do at the first setting or at the time of failure?
Because if we are not going to act on it, and I think that beyond EGFR, ALK and PDL1, there are no new adjuvant or adjuvant trial going on currently anywhere.
Yeah, as of now, since we have only an adjuvant osimertinib, So ALK also is not in place at this moment. Yeah, so we don't know the answers.
Now, as Dr. Arif said, ELK is actually very important because in most of the trial which is ongoing right now in neoadjuvant and adjuvant setting, they do at least these 3 markers. And if EGFR and ELK are positive, those patients are not offered PD-L1 therapy. So it is very important to do those 3 markers for sure.
Absolutely. So coming to the management of stage 3 lung cancers, so changing landscape in resectable NSCLs. So we have seen these slides getting more busier and crowded in a metastatic disease, and off late you can see also in a resectable disease, so dil mange more. So now, if you come to the NCCN 2022, so either on a CT scan or a PET scan, you think, so this is supposed to be a stage 3 disease, then how do you proceed, so, and so forth, so on. So this is from the up to date. So are mediastinal nodes involved? If no, then the treatment can have surgery, it can have adjuvant platinum-based chemotherapy. So followed by additional treatment for select group of patients, radiation for those with a positive margin, and osimertinib for those who are EGFR mutant. If yes, then what is the nodal extension? Is it N2 or N3 disease? For N2, so concurrent chemoradiotherapy using a platinum-based chemotherapy, or induction chemotherapy in certain patients followed by surgery. And if it is a N3, then it has to be a concurrent chemoradiotherapy with a platinum-based chemotherapy, and today the new armamentarium is there, it should be followed by durvalumab. So, Dr. Anil, so what is your comment on incidental stage 3A, that's N2 disease?
Incidental stage 3A N2 disease is usually will not be there if you have managed or if you have staged the patient very aggressively as far as the PET-CT scan is concerned and the EBUS is concerned. If you have done that, the chances of having incidental stage 3A N2 is very less, approximately less than 10 to 15%. So you are not going to find any incidental stage 3A N2 disease. But even if you get that incidental stage 3A N2 after you have done the surgery on a histopathological report, then it is not going to change the management as such because the surgery has already been done. So whatever, if you have given the neoadjuvant chemotherapy or whatever is the neoadjuvant therapy, then it is not going to change the management. As far as the post-operative radiation therapy is concerned, the recently published, the Lung R2 trial have shown that there is no OS benefit as well as the DFS benefit in providing stage 3A N2. But for example, if you have given neoadjuvant chemotherapy just for the sake of it because it was T3, T4 and N0, then you have an N2 disease at the end of the histopathological report, then I don't think so there is any need for changing the management.
Actually, just one thing I want to add. I completely agree with what he said. But I understand what you are exactly asking, that post-surgery, it is turning out to be N2 disease earlier, right? Yeah. So if the treatment has been completed, surgery resection, then only one thing that we need to see is there in the notes, if the ENE is present. If I go strictly by the guideline, the ESCO guideline, I would say. So if ENE is present, then definitely we can bring in radiation. JP sir is the right person to comment upon it, but I think radiation has a role if ENE is present. Rest everything I completely. Yeah, and of course margin. I think I'm saying if it's the R0, so that means margin is not positive, but ENE is present, then we should.
At this point of time, I think masterly inactivity. Especially it's a single station,
right? Absolutely.
Small node, right? And if it's a left side, definitely masterly inactivity.
So patients in whom N2 disease is not suspected but nevertheless found post or intraoperatively, if N2 is discovered intraoperatively in the patients with clinical signs pointing to a possible N2 involvement, in other words, or inadequately preoperatively staged patients. So the ACCP suggests it is better to abort the resection and proceed first with the appropriate staging. So now coming to a role of post-operative radiation. So we know that positive margins are important as an adjuvant radiotherapy. So what are other points? So Dr. Anil, then JP sir.
Anil, go ahead.
So as we have said that the role of post-operative therapy is in an overall blanket is very limited in stage 3A non-small cell lung cancer who have undergone resection. But there are subset where we can actually see for those patients who will benefit or not. Those are the multi-station node positive or who have the multiple node positivity, another with the ENE. So if you have the patient with these three parameter, then we can discuss the patient or with the patient the role of post-operative radiation therapy. There is no level 1 evidence to say that. Even in, for example, multiple node positive or multi-station node positive or with ENE or with a large bulky node, there is no level 1 evidence, but we can discuss with the patient individually.
Yes, sir, you want to add something?
So I think, as Anil said, with better instrumentation of surgery, better understanding of three-dimensional anatomy, etc., the number of positive margins are decreasing. And hence, the role of radiation is also decreasing. We are also understanding the other impacts of radiation to the heart, etc. So definitely we need to be very, very careful that we should not cause excess mortality. And hence these trials are suggesting that please be aware that with radiation you need to be very, very focused. Only when there is a very, very high risk, you should offer
So
adjuvant.
what about Anita trial? No, we are not talking about Anita Ramesh, no? So Anita trial.
Yeah, I think, in Anita also, there was definite advantage in very few subset, but mostly it was not, only it was advantage in a DFS, etc.
Yes.
But now we are understanding that real benefit is in very, very small subset.
So 5-year benefit OS 8.6, DFS 8.7. So now, so this at this moment, it was more or less an hypothetical, but it is becoming a reality. So potential neoadjuvant strategy in a non-small cell. So many are ongoing phase 2 trials. So as of now, there is one last year, 2021, which is an FDA approved, that is Checkmate 816. So now a resectable non-small cell lung cancer, so we are doing a 3 biomarkers, so EGFR, ALK and PD-L1. So if it is a wild type, so then you have a choice for a single agent immunotherapy, you have a choice for a double agent immunotherapy, you have a choice for immunotherapy plus radiation plus minus chemotherapy, then chemoimmunotherapy, and last can be immunotherapy plus anti-angiogenic like bevacizumab plus minus chemotherapy. For an oncogenic addicted NSCLC, so it can be still a chemoimmunotherapy. So normally for a high PD-L1, so normally if somebody has a drug-eluting mutations in a metastatic disease, so we ignore the PD-L1, but this is not the same in case of a stage 3. And somebody who is an EGFR positive, so we can have an icotinib, erlotinib, gefitinib, and now osimertinib, and a crizotinib for a ALK positive. So these are potential neoadjuvant strategies. So this is going to be important in future. So for a locally advanced NSCLC, so now for a EGFR positive, so these are, I am talking about neoadjuvant. So EGFR TKI, then it can be an ALK TKI, somebody who is EGFR and ALK negative. So they are either a candidate for chemotherapy or chemoimmunotherapy or immunotherapy doublet. So early stage non-small cell lung cancer, so dil mange more. So we have been seeing for many cancers, especially yesterday we discussed about breast cancers and today lung cancer. So pre-operative chemotherapy has been shown to significantly improve overall survival in resectable NSCLC, but the absolute 5-year survival has not gone beyond a 5%. A strong association between pathological complete PCR, which is becoming important for all solid tumors, and survival following a neoadjuvant chemotherapy was something around less than 4% if you look at the range between something around 0 to 16%. But neoadjuvant immunotherapy for a resectable non-small cell lung cancer have shown promising activity in a single arm phase 2 studies. The only one phase 3, that is Checkmate 816, showed a higher rate of PCR on tumor resection and improved EFS compared to that seen with a neoadjuvant chemotherapy. So neoadjuvant immune checkpoint inhibitors plus chemotherapy have shown a promising efficacy in a resectable NSCLC. So 2 to 4 cycles, people have tried with 2 cycles, people have tried with 3 cycles, so 3 cycles showing more benefit. So 2 to 4 cycles of neoadjuvant immunochemotherapy are generally used in most clinical trials. So currently the consensus of the optimal period remains unestablished. So role of induction chemotherapy, Abhishek.
So if we talk about stage 3A disease, and we have discussed in the tumor board that patient is resectable, so or maybe borderline resectable, we should be giving a neoadjuvant therapy for the patients. And neoadjuvant chemoimmunotherapy, as per the Checkmate 816, which have shown a pathological complete response of 24% versus 2.2%. So we will give 3 cycles of nivolumab along with whatever chemo combination we are given according to whether it is a squamous or non-squamous subtype.
So Sarvana, so now induction chemotherapy followed by surgery. So as a surgeon, so what is your concern and so what you are not going to do?
So we've been part of clinical trials for the past 2 years now. We are doing neoadjuvant immuno as well as neoadjuvant EGFR TKI clinical trials. If you look at immunotherapy trials, the safety for surgery is a concern for all surgeons because some patients tend to have dense inflammation after neoadjuvant immunotherapy. So it has not been our experience, but we are obviously double-blinded, so we don't know which is chemo, which is immuno. There is actually one report telling that it's very difficult to do minimal access surgery for these patients because of the inflammation at the hilum when you're doing neoadjuvant immunotherapy. However, we have found that neoadjuvant TKI followed by surgery is not that much difficult. So most of the clinical trials, when they suggest us to perform open surgery, although they leave it to us, but they recommend open surgery for post-neoadjuvant immunotherapy clinical trial surgery situations because of the difficulty which is faced by surgeons. So this is the only concern. However, now the surgical technique, the post-operative, perioperative care have all improved so much that I think it's not going to be an issue.
So anybody had an experience off trial, on trial of neoadjuvant IO plus chemotherapy?
I have started a patient who started on 2 cycles. It's not done for surgery, but the interesting twist is that I had sent for NGS, it has come ALK positive.
What is positive?
ALK positive.
Oh, ALK positive. Okay. So what do you think? So Vinay, so what do you think as an IO in a neoadjuvant strategy? So what could be the possible advantage and disadvantage?
So actually for that
It is going to be a new standard sometime.
I know it will be because I tell you, trust me, this suggestion was from patient attender. He said like, sir, the data is there, please give you IO therapy. I was reluctant, he may require radiation, CTRT, that was my plan. So I thought giving IO followed by RT was difficult. Now with the ALK post thing was difficult, but I think in patients who are not biomarker, any pathway driven, you can give IO therapy in neoadjuvant setting.
So the advantage is being a downstaging and increased likelihood of a complete surgical resection, attack the primary tumor and eliminate micrometastasis early in the treatment, improve tolerance and compliance, access sensitivity and resistant to drugs. So provide additional time to identify unsuspected metastases and comorbidities and to achieve a smoking withdrawal. Shorten trial timelines and accelerate the evidence of PCR, so pathological complete response and major pathological response as surrogate predictor of OS. So disadvantages being immune therapy related adverse events which can delay the potential curative surgery. So potential for immune hyperprogression we have seen in an advanced stage, increased number of complications, increased duration, and so our surgical colleague will agree, so that difficult for a surgery. So there are a spectrum of challenges of a neoadjuvant IO in NSCLC. So it's not that, so it is going to be the holy grail for all comers. So there are challenges, there are all the opportunities. So this is a pooled analysis of neoadjuvant IO and chemotherapy in a non-small cell lung cancer. So from the literature search, one group with a neoadjuvant IO alone or IO in combination with chemotherapy, and the other one is a neoadjuvant chemotherapy alone. So you can see, so in the neoadjuvant IO plus minus chemotherapy, 10 studies, around 400 patients, and in the neoadjuvant chemotherapy, so 11 studies, around 1400 patients. So the evaluation was to look at an objective response rate, major pathological response, pathological complete response, surgical rates, and R0 dissections. On the right hand side, you can see those patients who received a combination of IO and chemotherapy, vis-a-vis only chemotherapy and only immunotherapy, the overall response rate, the major pathological response, pathological CR, surgery, R0 dissection, so everything, everywhere, it was superior. So IO plus chemotherapy was much superior in all aspects. So these are neoadjuvant IO and CT clinical trials. So many of these are phase 2 and only phase 3 that has been a checkmate 816, and it has been with nivolumab, atezolizumab, durvalumab. So all these have included up to stage 3A. So from ASCO 2022, so the NADIM-2 phase 2. So there's a lot of discussion on this trial. So anybody of my medical oncology colleague, Manish or Abhishek?
I'm not aware of this trial so
Yes,
far.
Abhishek, Binay?
We can't see the slides. I just want to tell you that before. So, not aware.
So actually this is an excellent trial. So this is why we started doing immunotherapy in the first place for all patients with locally advanced. The major pathological response rates and the complete response rates are out of the park. We never used to see beyond 10 to 20% MPR rates or PAT-CR rates. Now it's almost up to 40%.
So looks like practice changing?
Yeah, it looks practice changing. I think in the future, especially when we know that when we operate these patients, more than 70 to 80% are going to fail. And if you're able to give them a chance, I think we'll salvage around 30 to 40% more patients once you do this strategy.
So this was basically a 2:1. So nivolumab at 360 every 3 weekly with a paclitaxel 3 weekly for 3 cycles. And the patient goes for surgery, and thereafter you can put them on adjuvant nivolumab, that was 480 every 4 weekly. And the control arm was only a paclitaxel, then surgery, and then they were observed. So the primary endpoint.
Biswas, but I have to warn you on this. Many phase 2 trials are so attractive in life, na? They always say, catch the star, but they fell most of the time flat. So I know that you need to wait really, you know.
Yeah, if 100 people try, at least one will reach that star.
Checkmate 816 of phase 3, it has
What I'm
shown.
saying,
Absolutely.
open the eyes, be cautious.
Yeah, we've seen the past. So the primary endpoint was a PCR in the intent to treat population, and then the rest were the secondary endpoints being a major pathological response, then the other biomarkers like looking at the ctDNA, and definitely a tolerability. So NADIM-2 actually the primary endpoint of PCR was made, and you can see this. So you can see so the patients with definitive surgery. So you can see a nivo plus chemotherapy. So 9 out of 10 patients could undergo surgery, where less than 7 patients in the only chemo arm. And if you see the pathologicals here, which is around 40% in the nivo plus chemo arm as compared to not even a double digit in the chemo arm. And so as the major pathological response, which was more than 50% in the combination arm, which was much less in the only chemo arm. And again, coming to overall response rate, almost 8 out of 10 patients were responding to these combinations, where less than 50% were responding to only chemotherapy. So definitely, so once you are adding more drug and another drug of different mechanisms, so we expect some newer toxicity, but no grade 5 toxicities. The secondary endpoints were also made. So they looked at the PDL1. So that's how, so we talked about EGFR, ALK and PDL1. So they looked at somebody who has a PDL1 of less than 1%, where the PCR was 15%. Somebody who has a PDL1 of 1 to 49%, it was almost 42%. And somebody who has a PDL1 for more than 50% is what we do in a stage 4 lung cancer. So 6 out of 10 patients has a major pathological response. So probably, as JP sir rightly said, so we need to move into a bigger trial, that is phase 3, and then probably it can be a game changer. So difference between a checkmate 816, which got FDA approved last year, versus NADIM-2, which was presented this ASCO. So we can see, so checkmate was a phase 3, so as a level 1 evidence, versus this one as a phase 2. And so all squamous and non-squamous both were represented. But you can see a bigger chunk of patients into PCR in this phase 2 NADIM trial. So there is another trial also, NeoScore, which is looking at 2 cycles of chemotherapy with immunotherapy versus 3 cycles. And that showed that so major pathological response and PCR are much more when you are offering 3 cycles of neoadjuvant chemoimmunotherapy as compared to 2 cycles. So 3 cycles treatment presented almost 5% increase in a PCR rate. So I don't want to go into this. So MPR versus PCR in various so this will be a new terminologies in lung cancer. So major pathological response and pathological responses in the, so you can see the Nadine 2 trial stands out amongst the whole cohort. So surgery after neoadjuvant IO plus chemotherapy, so as Sarvana rightly said, so more difficult due to dense inflammation, conversion to open surgery in more than 50%, morbidity, mortality relatively safer except durvalumab. So major pathological response and pathological CR rates are higher than the neoadjuvant chemotherapy and the neoadjuvant chemoradiotherapy. So neoadjuvant IO is more cost effective compared to the adjuvant IOs. And so patients with resectable stage 3 disease with a higher PDL1 score may be a best suited for this approach. So molecular profiling of earlier stage non-small cell lung cancer is now becoming increasingly necessary. That doesn't mean that you are going to do NGS tomorrow, but probably, yeah, so there are options. So neoadjuvant EGFR, ALK, so these are in the trial setting, so these are as a neoadjuvant, this is not in practice, so there are n number of trials with the first generation anti-EGFR, especially arlotinib, gefitinib, and there are neoadjuvant with ALK also, very few number of patients, so probably this is only a food for thought at this moment. So coming to an adjuvant TKI EGFR, so what is your take, Abhishek, on the ADAURA trial?
So yeah, as Dr. Ullas also discussed very well, that ADAURA, based on ADAURA trial, we can give adjuvant osimertinib for 3 years for post-op patient who are EGFR positive. And it has shown a DFS advantage, although overall survival data is still not mature. So till now, we can give osimertinib for such patients.
Manish, so ADAURA is adorable?
Yeah, I have been using in my patients, though of course cost remains a concern. I feel more encouraged to use in patients who are even earlier stage, say stage 1, or in fact in one of my stage 1 patient I have not even given chemotherapy, only adjuvant osimertinib, so that's what I'm doing. So I have been using it with the cost remaining a concern. That's all.
Yeah, so these had patients who have received chemotherapy, and they have patients who haven't received.
So would we use in 1B also, or only 2 or 3As? The
So
primary
1B,
endpoint
2
was
and it says 3A, all the three, no?
1B also.
Yeah, so I showed there. So 1B, 2 and 3A. Though and 3A, because since we were discussing on stage 3, so stage 3 in this trial was almost 1/3. So 1/3.
All the clinical trials are smartly including patients from 1, 2 and 3. There are very few trials which have included only 3. So they're very smart. So they want to push.
Because ultimately at the end, so if the trial is not positive, so at least a subset of
the
might
patient,
come
yeah.
positive.
So I think.
So you can see the primary endpoint as it is, the OS has not matured, but yeah, stage 3A patients, the improved DFS over those patients who are receiving only chemotherapy or the patient who are not received anything. So unresectable stage 3 NSCLC, the challenges, so local regional control, systemic control, brain as a sanctuary site for metastasis. So Arif, so how important is, so we talk about brain as a sanctuary site for many cancers, so how it is important for stage 3?
So unresectable, I will do Pacific only. It's like CTRT followed by durvalumab, unless it is maybe mutation-driven cancer. Though when the trial was enrolled, they are not included the criteria as EGFR, they have not done at that time, EGFR ALK. But any unresectable, I would go for chemoradiation followed by durvalumab.
Right. So coming to Dr. Anil, so radiotherapy alone, sequential chemoradiotherapy or chemoradiotherapy. So is there a place for all? So or all said and done, it is chemoradiotherapy only?
For all patients, it should be concurrent chemoradiation therapy if the patient general condition is good. However, if the patient general condition or if there are any comorbidities that preclude doing the concurrent chemoradiation therapy, we can obviously change the sequence from concomitant to sequential. But there is no, if the patient is chemotherapy suitable, there is no place for radiation therapy alone or chemotherapy alone. we should be having the chemotherapy plus radiation therapy, and in view of the Pacific trial, we can add the adjuvant durvalumab.
Right, so absolutely from the meta-analysis, around 40 trials, around 7,000 patients, you can see, so chemoradiotherapy, the absolute benefit is significant. Yeah, there is a place for sequential CRT, so probably looking at the toxicity part. So now, concurrent CRT versus sequential CRT. So OS and PFS in favor of concurrent CRT, even there is a decreased risk of loco-regional progression, but there is no difference in rate of disease distant progression. So JP sir, so how important is an acute esophageal toxicities versus pulmonary toxicities in both these modalities? So concurrent versus sequential.
I think across, whenever we are making it more intense, toxicities are going to be very, very carefully monitored. So that may be esophageal, may be one of the dose limiting in the sense that the compliance become a challenge for a complete dose. So we need to be very, very aware of right from the beginning, and we need to see that we are taking over it, and as we expect because of the dose or because of the fungal infections, we have to be very careful on that. So most of the time you like to give always concurrent, but at times because of the high length, we need to sort to sequential.
Absolutely. So reasonable treatment options for patient with stage 3. So concurrent chemoradiotherapy, induction chemotherapy followed by concurrent chemoradiotherapy. But yeah, there is no place for concurrent chemoradiotherapy followed by a consolidation chemotherapy. And so Abhishek, so what are the options of chemotherapy while the patients are put on radiotherapy as a concurrent protocol?
So data we have is for cisplatin etoposide, cisplatin vinorelbine, and now for if we talk about histologically based, then for pemitasted cisplatin for those who are having a non-squamous, and cisplatin paclitaxel can also be given for those with squamous on both the histology. So there are multiple options to choose from, and most of the time we are using cisplatin along with etoposide.
So Dr. Anil, so now you think that, so with the concurrent chemoradiotherapy according to the RTOG 9410, so there can be 1 out of 5 patients who can be a long-term survivor?
Yeah, so the 5-year survival is approximately 25 to 30% in the recent phase 3 RCT. However, with the addition of durvalumab, so we can increase the 5-year survival to up to 45%.
So Manish, so do you think that we need to ensure that all eligible patients with stage 3 receive concurrent chemoradiotherapy? Because according to the retrospective charts, so vast majority of the patient with stage 3 NSCLC, because I was a part of that Kindle study, so where we looked at and really found out that so many eligible patients were not offered concurrent chemoradiotherapy for various reasons. Either they don't have a radiotherapy centers, or there was no tumor board decisions, or looking at the toxicities. But registry data showed that 50% or fewer of these patients received only out of, suppose, expected 100 for in this setting.
No, I didn't get your question, sir.
No, so do you think that stage 3 is optimally not staged and they are not offered the standard of treatment as a CTR?
Well, this is the standard, and we should always try our best to give chemo radiation, especially concurrent, to all stage 3B and certainly stage 3C patients. So that's the endeavor, and followed by adjuvant durvalumab. So most of the places people are trying that.
So coming to the concurrent CRT summary, so stage 3 locally advanced is heterogeneous, and many of these will be unresectable disease. So 8th edition of TNM classification made into a stage 3A, B, C. Expert recommend invasive staging procedure for NSCLC. So before era of immunotherapy, that was the Pacific trial. So concurrent chemoradiotherapy plus minus induction chemotherapy demonstrated 20 to 25% of cure rate. So multiple strategies to improve survival in this setting tested without success. So advanced radiotherapy techniques have led to a safer or more efficacious treatment of patients with that stage 3 NSCLC, yet according to the registry data, 50% or fewer of these patients received. So JP sir, so with the advent of precision radiation, so does it making changes so in the survivorship?
Certainly, I'll give you, I think, why only 30%, 50%. because it was a heterogeneous group, you know. So if I can divide in as classically to others, I also say patient factors. If the patient are not performance status not good, or the tumor factors means the tumor volume was too large, or the machines were not there, right? So all this makes them like earlier pleural effusion was a part of stage 3B. So that makes them as less. But as we advance, understand that dose to the heart is important. So I think definitely like machines like proton, etc., will make them more attractive and give the higher survival. And also we will understand the biology of mutation positives versus non-mutation positive. I think we still need to know much more from a radiation perspective, but definitely I think it is not the last case as earlier what we used to say, acha, small dose, forget about it. It's not like that now.
So lack of progress before the Pacific study. So incorporation of new chemotherapy did not work. In induction consolidation strategy never worked. Incorporation of targeted therapy like anti-EGFR, vaccine strategy, and even so dose escalation of thoracic artery. So pre-radiotherapy, so if you look at the milieu, so the immature dendritic cell, less antigen release, and the CTL inhibition. And post-radiotherapy, so we are actually changing the tumor environment and priming the dendritic cells, increased antigen release, upregulation of the PD-L1, upregulation of the immunogenic cell surface markers. So coming to Dr. Arif, so what is your experience and take on the Pacific study?
I tried in a couple of patients. They are done very well till now. They are in remission. After these two patients, 1.5 years till now, they are doing well, sir.
Yeah, so it was basically a placebo versus durvalumab 10 milligram per kg every 2 weekly, and for 12 months. There was a co-primary endpoint of PFS and the OS, and the primary PFS and OS was met. So it included squamous and non-squamous. It included stage 3A and stage 3B. It included low PDL1 and high PDL1, and also 1/3 patients where we did not knew the PDL1. So induction chemotherapy versus only a definitive CCRT, induction followed by CCRT, and these were different prior RT was also there. So all patients who had some responses went on to the durvalumab arm. So only patients who progressed were not included. So you can see the survival curve here, PFS and OS. So in the PFS, so you can see a durvalumab 16.8 versus 5.6, so way far away. In the OS also, it did not reached in the durvalumab arm versus the placebo. And if you see the forest plot and PFS and OS favoring durvalumab in all aspects. Even if you see at the bottom, even EGFR positive patients were benefited, which you normally don't see in a stage 4, but here in the stage 3, they were still benefited. So this looks like that we have a different biology, and as we said, it's a heterogeneous group. So impact of prior chemotherapy and dose of RT on survival. So you look at durvalumab, so be it a cisplatin or a carboplatin, be induction chemotherapy or no induction, taxanes, yes, no, etoposide, yes, no, vinorelbine, yes, no, dose of radiotherapy less than 60, 60 to 66, and more than 60. So all comers were benefited with the durvalumab maintenance. So at this moment, at 3 years, you can see, so 57% versus 44 in favor of durvalumab, and this is the updated. So any new lesion in the durvalumab arm was 22.5 versus almost 10% extra in the placebo arm. So these are outcome and adverse events. So incorporation of durvalumab, which became a new standard today. So RT induces multiple immunomodulatory changes that may influence immunotherapy efficacy in patients with stage 3 NSCLC, and good performance status. Concurrent platinum-based chemotherapy followed by consolidation durvalumab is the standard of care, and the Pacific trial has shown us the way. So there were initial papers of Keynote 042 with a single agent pembrolizumab, so that though that is in the guidelines, but many authors, many speakers have not recommended this. So multidisciplinary, what is more important MDT for a stage 3 lung cancers. So lots of clinical trials are there and probably will help us in future to have paradigms or different armamentarium in stage 3 lung cancer. So lastly, thank you for a patient hearing, and I especially thanks my first year DM student, Dr. Sushil Kumar, for helping me with the slides, and also Dr. Sarvana, who gave us his surgical inputs. So thank you so much. Thank you, Chairperson, Session Director, and all my panelist colleagues. Thank you so much.
Thank you so much, sir.